topic today is about hypoxic ischemic encephalopathy, which is a common condition that we all have to look after, not only in the UK, but also in Uganda and globally. And it's one of the biggest causes of neonatal mortality. And so we're really lucky today. We've got two teams presenting. We've got a team from Mulago Hospital in Uganda, and then we've got a team from Harrogate presenting. So this is a pretty informal teaching session, and so there's a chat option. So if anybody would like to put any options for questions or comments, then please do so in the chat, and we'll be monitoring that as we go along. But there will be at the end of both presentations an opportunity for questions and then discussions. And I think those of you who've attended these grand round before will recognise and appreciate they're really good learning opportunities, and the UK teams can learn from Uganda and vice versa. So I'm really looking forward to today's session, and a big welcome to everybody. So I'm going to hand over to Dr. Helen and Nurse Clare from Mulago Hospital, and they're going to be doing the first presentation, which will be a case presentation about HIE, and then Nurse Clare is going to talk about the management of HIE in Mulago. So Dr. Helen and Clare, you are most welcome, and I'll hand over the platform to you. Thank you.
Thank you. Greetings to you all. From Uganda is me, Helen, Kyokutambe, and Clare. We both work at Mulago Specialized Women and Neonatal Hospital, where we run a tertiary level neonatal intensive care unit. It is a 63 bed capacity NICU, where we offer different levels of care, level 1, 2, 3, and 4. So I'll be taking you through a case presentation of one of the babies we managed with HIE, and the different lessons we learned from the case that we managed. And we also look at how we improve, how we can learn to improve the care that we give to our babies. Thank you. So I'll be presenting together. I'll present the first session and the first part, and Claire will be taking over the neonatal nursing component of the presentation. Thank you. Yeah, so that's the objectives today is, like I said, we're going to present our case and give an overview of management of HIE in Uganda, and also discuss challenges that we face in management of HIE, and together we can develop and learn strategies for improvement. Yeah, next. So I'll present a case. We have a mother who was called KM, so the baby was a baby of KM. The mother was 23 years old, and was born to the baby was born to a para 1+0 mother. So this baby came to us as a referral from a district hospital. She had attended antenatal care and delivered at a district hospital, which is approximately 80 kilometers from the national referral where we received the care. So this mother attended antenatal care at the district hospital and delivered hospital, but notably she came to the hospital to deliver when she was in second stage of labor, and she delivered a term baby who scored an APGAR score of 2 at 1 minute and 3 at 5 minutes. From the referral notes we saw from the history took from the mother, the baby was resuscitated using bag and mask ventilation. Baby was resuscitated for over 30 minutes. And there was some slight improvement, and the baby started to regain some spontaneous breathing. And at that point, the baby was prepared for referral and was referred to Kawempe National Referral for further management. And then at Kawempe National Referral Hospital is the other national referral hospital apart from Mulago Specialized Women and Neonatal Hospital that we have, and they are located close to each other within the city. So this baby was first referred from a district hospital, which is about 80 kilometers away from the city center, and they came to Kawempe National Referral. But then from Kawempe National Referral is the other hospital, which then referred to us at Mulago Specialized Women and Neonatal Hospital, because they had run out of space for ventilating the baby, and they thought the baby needed ventilation, and that's why they referred the baby to us. These two hospitals, like I said, are close to each other, so the baby came to us 2 days later from our sister National Referral Hospital. Next. So when this baby arrived to us, when the baby arrived to us at Mulago, which is the National Referral Hospital, the ICU, it was by then the 4th day of life, having come from the district hospital to the other national referral, and then finally to us. This was the 4th day of life, and we noted, yeah, it was a term baby who had a birth weight of 3.2 kilos. At arrival, the baby had a temperature of 33.2. That was the accelerated temperature, and the SpO2 on CPAP. This baby was transferred on CPAP and arrived at Mulago with an SpO2 of 91 while they were on CPAP, and had a pulse rate of 103. So notably, this baby was really sick, was having convulsions. There were focal seizures in the upper limbs. This baby had absent reflexes. The bladder was full. There was urinary retention when we examined on the abdomen, when we examined the abdomen, and this baby had shallow breaths and had brief apneic episodes, but which were not associated with desaturation or bradycardia. So, and also when we did the scoring, we used what we call the HIE Thompson score for us to categorize the severity and manage accordingly. So when we scored according to using the Thompson score, we saw that this baby had a score of 18 out of 22, which would categorize that as severe HIE or HIE3. So notably, this baby also had cold extremities, had weak pulses, the abdomen was scaphoid, and had been referred with an NG tube in situ, which had bloody aspirates. So when we admitted this baby, the baby was very sick, so we knew the diagnosis we had was HIE3. Because of the bleeding, we thought the baby was having a coagulopathy, but we also were cognizant that there was also a differential diagnosis of NEC. However much we had bowel sounds which were close to normal. We thought could also have been NEC, necrotizing enterocolitis, and also neonatal sepsis was one of the other diagnoses that we thought of in this baby. Next. Next slide, please. So this is just a representation of the score chart that we have. Next, please. Yeah, so this is the Thompson score, which we commonly use in our facilities in Uganda to help us categorize the babies in terms of severity of HIE. So what we did when the baby came, we did a full blood count, we did a CRP, we did RFTs, and a cranial ultrasound scan. So the septic markers, it was a CRP, which was slightly enlarged, and so notably the baby had a hyperkalemia, hypernatremia, and the renal functions were deranged. And on the cranial scan, this baby had generalized edema, but there was no evidence of any intracranial hemorrhage. So because the baby came in convulsing, the first thing we did was to give a loading dose of phenobarbital, because we didn't have a clear history. We knew that the baby had received 1 dose of the phenobarbital before referral, but we are not sure if they had received others even before they arrived at our hospital on the 4th day. So we also gave this baby normal saline bolus, because this baby had signs of shock, had poor perfusion. So at that point, the baby was able to maintain target oxygen saturations on CPAP. They had brief apneic episodes, so we continued the baby on CPAP for about 12 hours. And then suprapubic puncture was done to relieve the urinary retention. And we kept the baby on, we did not feed the baby. We kept the open NGT drainage and started the baby on neonatal cocktail infusion and stopped them from feeding the baby. For the bleeding, we initiated vitamin K and transfused this baby with fresh frozen plasma. And this baby was really hypothermic at admission, so we rewarmed the baby under radiant warmer and started IV cefotaxime for the neonatal sepsis. Next, please. So while the baby was with us, on the next day, the baby deteriorated and started to desaturate while they were on CPAP, and the apneic episodes became long. So at that point, we put the baby on mechanical ventilation, and also notably, the baby had the bradycardia was worsening. So we gave another normal saline bolus, and whenever I would give the bolus, the heart rate would improve. So we gave a bolus, and because the baby still had seizures, we started the baby also on midazolam infusion after putting them on mechanical ventilation. So on the next 2 days, we noted that the baby had worsening edema. The diapers did not have any urine, were not able to get any urine even on catheterization. And at that point, because the seizures had stopped on midazolam infusion, but the baby still had weak pulses, and we did a BP. And the map was showing that it was 40, which wouldn't be so bad, but because the baby had signs of poor perfusion and was still having bradycardia, we started this baby on dobutamine infusion, and the heart rate progressively improved over the day. So over the next, and on the 7th day of life is when we noted that the baby, the aspirates, the bleeding had reduced, and were able to start the baby slowly on expressed breast milk, and we gradually increased. I didn't mention it, but when we repeated the investigations, the septic markers were getting worse, so we stopped the cefotaxime and went to our 3rd line of management of sepsis. And so we started this baby on meropenem and stopped the 2nd line of antibiotics we had started this baby on. And eventually the seizures were reducing by the 8th day of life. We were not having any breakthrough seizures, so we weaned this baby off midazolam. And eventually we were able to wean the baby off mechanical ventilation on around 10th day of life. So this baby was ventilated for about 3 days. Over the next few days, from day 9 to day 15 of life, this baby improved, had a better urine output, and were able to continue increasing the feeds, completed the antibiotics. However, this baby also got ventilator-associated pneumonia, and we also started to do physiotherapy, chest physiotherapy, because this baby was also flaccid, and we did physiotherapy to improve the tolerance to CPAP, because initially we were desaturating on CPAP, but we managed the vent-associated pneumonia and were able to wean the baby off to CPAP and eventually to free flow oxygen. And progressively the baby improved, and we discharged after a whole month. And this baby, by the time we discharged, was not able to breastfeed. The suckling reflex was not good. So we counseled the parents and counseled them about the prognosis, and were able to discharge the baby while they were still doing NG tube feeding. So this is one of the cases that we've managed typically at Women's Hospital for HIE. So a few things to highlight about in this. So you see, we received this baby with severe hypothermia of 33.2, and probably could have contributed to the the worsening clinical condition of this baby. So the question I have is, should we actually be practicing this in our facilities? Of course, there are different papers that have been written about this. And there's been a concern that when we practice hypothermia in a way which is not appropriate, we actually worsen the outcome of this.
On nursing management on admission, like how Dr. Helen already described the baby, we continued with temperature monitoring because in our setting, we are unable to do therapeutic cooling. We try to monitor the temperatures and maintain them in normal ranges of 36.5 to 37.2 degrees centigrade. And also respiratory support on admission who the baby was on CPAP. So we maintained continuous assessment of check for breathing rate and also increase in apneic episodes. Then the baby was also put on NILPA-OS in view of bloody aspirates. So we were able to keep on IV fluids and also give bolus of normal saline 32 mils. IV fluids, we used the neonatal cocktail in our setting. We also gave IV medications, especially the phenobab on slow infusion, and vitamin K due to the bleeding, bloody gastric aspirates of 1 milligram per kg, and also ordered for FFPs that the baby received. There was urine retention, so suprapubic puncture was done by the doctor. However, as the nurses team, urinary catheter was inserted to be able to monitor and maintain a fluid input and output so that we are able to assess the renal function of this baby in to rule out any renal injury. Also, for poor perfusion, the baby was put on stockings to be able to manage the cold extremities and anyway warm the extremities. So our progressing nursing management on day 2, the baby's breathing, the baby respiratory support needed ventilator support. So the baby was put on a mechanical ventilator. We kept further assessment for hypoxia, and our SpA2 ranges were in the normal ranges. So the baby was maintained on mechanical ventilation. We also continue monitoring the infant's level of responsiveness, especially to assess if the baby is responding to the treatment and activity, muscle tone, and posture. So daily we assess these babies using the HIE score so that we are able to assess. Also continued administering the prescribed medication, antibiotics, the phenobarbital. Then also we kept an adequate perfusion and also monitored the BPs within the normal ranges, though they were the BP across were slightly low, but we were able to maintain them in the normal ranges by ensuring that the IV fluids were given well. Next slide, please. Our RBS was in the normal ranges as well, and electrolytes which were beat up kept on reducing as the days went by. Also, our thermoregulation support, since we are unable to provide head cooling, we ensure that we avoid hypothermia and maintain the temperature regulations in between 36.5 to 37.1. Next slide, please. So our babies' seizures were controlled with and the drugs that were prescribed. At first, the baby's nutritional support was kept on nil per hour until the aspirates were clear and were able to start on EBM gradually until and also as we continue to watch out for signs of neck, especially in stool and urine. Then also education to the family is very important in such babies, especially to involve them and continue care while at home, especially with the feeding, since the baby was discharged while still unable to suckle and still giving EBM through NG tube. So the mother here is educated on how to keep the feeds, on continuing physiotherapy while at home.
So there was a question about what we like the phrase neonatal cocktail. Just wondered whether you could tell us what's in your neonatal cocktail for IV fluids.
So the neonatal cocktail we use does not have amino acids. We have half-strength Daros, and we add in that's to cater for the electrolytes, and then we add in dextrose 5% and 50% to make a cocktail which is balanced for the babies. It doesn't have amino acids though. The ideal would have gotten amino acids, but in this case we did not do that.
Can I just ask you a question, Dr. Helen? There's a question that's come up in the chat, which was the baby, because the baby arrived with a very low temperature of 33.2. Was that just because the baby got cold in transfer, or was that for hypothermia purposes? Was that therapeutic hypothermia?
Yeah, so the temperature was low partly because of the transportation process, but also it is very common that you'll find these babies have a very low temperature because of just leaving them to passively cool. And in most cases, we have challenges with dealing with the outcomes of this. So we have a few centers here in Uganda, which are mostly private, where we're able to do therapeutic hypothermia. But in our government facilities, we are not yet able to, because it is a therapy that needs intense. It needs resources, especially the human resources, the monitoring tools, and equipment, which we may not widely have. So one of the things that I would love as a take home from this is should we actually continue to actually do this passive cooling in our babies if we are not able to monitor them closely, because this may actually be worse and improve and worsen the outcome compared to actually keeping them within the normal recommended temperature ranges. That's one of the lessons that I learned, but because I know I've not seen it just because of transportation, but it's a common practice in most places. The baby is just left to passively cool, and then we're not monitoring to see what actually is happening. How is this baby's blood pressure? How is the baby at risk of bleeding? All those things that we need to do if we are doing therapeutic hypothermia may not be done.
There was a question about whether it was necessary to continue with phenobarbital after discharge. I know that our practice in the UK is that if the baby continues to fit, then we would send them home on some maintenance phenobarbital.
Seizures. This baby seemed to have started seizuring early alone and had been given multiple doses of phenobarbital. And by the time we came, we also give another dose. So after 4 days of probably having seizures, we are still giving phenobarbital, and we've not yet moved to the next level of care. We have different protocols. At Mulago, we use a specific protocol. If phenobarbital does not work in some centers, they will use phenytoin and then go to midazolam. But I think there was a gap there, and maybe if we can closely follow up and be able to identify these seizures. Unfortunately, some of them are subclinical, and we are not able to do the continuous ECG monitoring, but we should anticipate. So when should we actually start to give these babies anticonvulsants, even when you're not seeing them, if they have HIE3 according to the grading we've done? Then the other issue was the hemodynamic management of this baby. This baby was bradycardic, And eventually were able, probably also contributed to the worsening renal failure. Later were able to identify it and start the baby on the inotropes. But it's also something that I think from this case I learned that we need to pay attention to also managing the hemodynamic of these babies who have HIE to improve their outcomes. Thank you. I'll take any other questions.
There was a question about follow-up. How do you support the family and the patient once you've sent them home? And how do you follow them up?
So these babies, when we are preparing them to go home, of course we tell them about their long-term outcome, and we talk to them about the care. But specifically, we send these babies through the neurology clinic, where they are able to do a neurological assessment and an EEG, and we're able to go to the next level of anticonvulsants if they are needed, and they're able to get the physiotherapy if they need it, and they're able to get all the continued care. So we run a postnatal clinic where we're able to follow up these babies and look out for later complications and manage them and do psychosocial support for the parents to be able to take care of these babies. Thank you.
Thanks very much, Helen. So obviously I think the discussion is really about sort of cooling therapeutic hypothermia in low resource settings, and the evidence currently is that it shouldn't be supported in lower resource settings. And Kathy's put something in the chat. I can see there was a comment about doing some selective head cooling with ice packs. I think what we found in the UK in terms of referral hospitals starting passive cooling is that actually you can over passively cool. And I presume, Helen, I was just wondering how you would monitor a baby's temperature. Is that central temperature or is that just axillary temperature?
That is the axillary temperature. We were monitoring our baby using axillary temperature, but we, of course, in our setting, we don't yet practice therapeutic hypothermia because of not having enough resources to do it. But we would need to do the core temperatures. However, in this case, we were doing the axillary temperature for the baby. So in our hospital, we are not yet able to do that. It's next level of care we need to go to, but because we don't yet have the resources, we are not yet doing it.
Yeah, and I think the evidence that comes out of the Helix trial that Kathy's just put in as well in the chat shows increased mortality. So I think in a low resource setting that we shouldn't be supporting therapeutic hypothermia.
Yes, can I just add maybe just for everyone? So the Helix trial is like the biggest study done on cooling in a middle income setting. Everyone should go away and read it. It's a fascinating study. I've heard presentation from the guy who led the study in Africa, in America last year. It's very controversial is what I would say. You know, people in cath setting, it's just normal to cool, and we really, everybody who works in our setting in Uganda or low middle income countries really wants it to work. So people are still exploring it. You have to be very brave now to do that kind of trial because of the trials that have gone before and showed increased mortality. But people are still looking at it. But as per now, the evidence says that in our setting, with limited resources and higher rates of infection, and also a completely different etiology of our HIE, where the brain injury happens a lot longer before delivery. And so we've missed that 6-hour window to get to the cooling, effective cooling period. We as a group should be focusing in Uganda on normothermia, so making sure the babies are not too cold. And like Dr. Helen, I think it was actually Clare, pointed out, we shouldn't allow these babies to heat. As they heat up and go above normal temperatures, it's actually probably even worse for these babies. So many of you have asked that question in the chat, but for all of us, trying our hardest to use what's available to us, blankets, skin to skin, hats, just to maintain the temperature in the normal ranges is the way to go for now. But we all need to keep our eyes and ears open for any new research that comes forward to tell us how to safely cool in a setting like Uganda. Thank you.
Thanks, Kathy. That's really important. And I think it seems to me that the case you presented, Dr. Helen and Clare, was extremely complicated, and you managed to look after the baby extremely well with some, you know, and as well as just doing supportive treatment, you know, just getting the electrolytes right, correcting a coagulopathy and managing the fits, which you did extremely well. but I'm going to introduce now the team from Harrogate. So we've got three people presenting today. So we've got Erica Mclean, who's a paediatric trainee, who's going to go first with a case. Then we have Mona Basu, who's a consultant paediatrician, who's going to talk about the guidelines and the background information to HIE. And then finally, we've got Jade Kant, who is a paediatric physiotherapist, who's going to talk about how she would manage babies with HIE. So I think that will answer some of the questions that I see popping up in the chat about follow-up and physiotherapy. So thank you very much, Harrogate team, and I'll hand over to you.
For those of you that don't know where Harrogate is, it's a small little town on the edge of the Yorkshire Dales, 30 minutes north of Leeds.
Hello everyone, I'm Erica. So I've got two cases to share with you. They're both quite similar and quite brief, but we'll just go through them one by one. So it's not moving. So our first case is a term baby born at exactly 40 weeks gestation. So it was a low-risk pregnancy. It was midwifery-led care. Mum presented in spontaneous labour and was actually in our pool room at Harrogate Hospital. And then whilst she was having monitoring, there was a prolonged fetal bradycardia whilst mum was in the birthing pool. So she was quickly removed out of the pool and baby was born fairly imminently via ventouse. So initially baby was born pale and floppy with no spontaneous respiratory effort and a heart rate less than 60. He required 2 sets of inflation breaths via the 2-patient technique with a jaw thrust to obtain any form of chest rise, and then a further 2 sets of inflation breaths to get the heart rate above 100. Following that, he had quite a poor respiratory effort, so had 30 seconds of ventilation breaths requiring up to 50% oxygen. But by about 12 minutes of life had regular spontaneous rests and was then transferred across to SCBU at 23 minutes of life. So in SCBU, on initial formal examination, he was grunting with some nasal flaring and had subcostal recession. His temperature was just about acceptable, but he had a delayed central capillary flow of 3 seconds, and the initial capillary gas you can see there. So because of that clinical picture, baby was given a 10 ml per kilo fluid bolus and was started on first-line antibiotics once IV access was obtained. So about 30 minutes to an hour later, they had a repeat gas, which again you can see there. And based on the clinical picture and the gases that were obtained, the consultant on call discussed the case with Embrace and just asked for some advice, and together the decision was made that the baby needed to be cooled. So in Harrogate we can't do that, so Embrace, which those of you who don't know is our regional paediatric and neonatal transport service, came. The baby was intubated and ventilated prior to transfer and then was transferred to Leeds for cooling. So in terms of the outcomes, the baby was transferred back to us on day 8 in air and with no other medications. He was cooled for 72 hours. Had normal cerebral monitoring whilst he was at Leeds and had a normal cranial ultrasound whilst he was there. Just before he was discharged back to us, he had an MRI which showed a possible tiny area of ischemia, but Leeds were not concerned about that and were happy that he didn't need any particular follow-up or further investigations from them. He could just be followed up locally. He was seen in clinic at 6 weeks and had normal development at that stage and was progressing really well. So there are no other concerns. And then he was followed up routinely after that and was discharged 2 years later when he had normal development. So the second case has a very similar background. So again, it's a low-risk pregnancy, baby born at 39 plus 1, with no antenatal concerns and no sepsis risk factors. Was born via emergency section due to failure to progress, and there was quite a difficult extraction. Again, baby was born pale and floppy with a heart rate less than 60 and no respiratory effort. Needed 2 sets of inflation breaths to get good chest rise, and then had 30 seconds of ventilation breaths. But at this point on reassessment, the heart rate remained less than or around 60, so chest compressions were started. Whilst those compressions were ongoing, there were 2 attempts at intubation made by the paediatric trainees. They were unsuccessful, although throughout that it was noted that baby's colour and tone improved. And then baby was intubated successfully at 9 minutes of life by an anaesthetic consultant. And at this point, there was good bilateral chest movement with a heart rate well above 100. And then at around 12 minutes, there was spontaneous respiratory effort. The APGARs for 1, 5, and 10 minutes were documented there. So it was 0, 4, and 5 at 10 minutes. So baby was transferred around to Scaboo intubated. The cord gases were then available, which you can see on the screen. And once IV access was obtained, we got an initial venous gas. And a dextrose and saline bolus was given along with first-line antibiotics. Baby remained spontaneously breathing, so was extubated quite quickly at 45 minutes and was extubated straight to air and remained self-ventilating in air following that. So on the first examination done by the consultant, baby was mildly hypertonic, and at this point didn't have a Moro or a suck reflex. There was no active seizure activity and pupils were equally reactive, but the decision was made at about 80 minutes by the consultant to start passive cooling. And then this was discussed again with Embrace, who agreed with the plan and made a plan for therapeutic cooling and transfer. The baby was examined just prior to transfer and at this point had a completely normal neurological examination. This baby went to Sheffield and was discharged directly to home after a 10-day inpatient stay. So the baby had 3 days of cooling, had a cranial ultrasound whilst as an inpatient, which showed a possible infarct of the right middle cerebral artery, and then went on to have an MRI, which didn't show any signs of HIE. The baby also had an EEG, which showed an electrical focal seizure, but then had a repeat one just before discharge, which was essentially normal, apart from possibly showing features of a reduced seizure threshold. So baby was then referred to the neurodisability team and was followed up locally in the developmental clinic. But since then has been developing normally and has actually been discharged from both of those.
Thank you very much, Erica. So hopefully that's given you a bit of a flavour of how babies presenting with HIE are managed. So each of the units across Yorkshire provide quite different levels of care, ranging from level 3 neonatal intensive care units, such as in Leeds and Bradford, all the way through to the level 1 special care baby unit that we have here in Harrogate. And I would say it's probably the smallest unit in the whole of Yorkshire. We've got 7 cots to provide care for about 2,000 live births a year. So we cater for babies above 32 weeks gestation, those needing feeding support, oxygen, but we still need to be able to provide intensive care support and stabilise any sick newborn that comes in through the door, either through delivery suite or sometimes the emergency department. And then once we've stabilised these babies, we utilise our retrieval service, Embrace, to come and help us transfer these babies to the appropriate level 2 or level 3 unit, depending on their need. So today I'd like to talk to you about the HIE guidelines that we use in our level 1 unit. And they are mainly based on the landmark Toby trial from 2008, where the main aim is to initiate therapeutic hypothermia within 6 hours of delivery. And the earlier, the better, really, in terms of improving prognosis. So I'm just going to focus on the cooling aspect rather than going into the ABC management of dealing with a sick neonate. So Our guidance say that you should offer cooling to all babies who achieve at least one of criteria A and criteria B as well. So criteria A is pretty straightforward. It affects all infants more than 36 weeks gestation. And if you just need to have one of either a poor APGAR at 10 minutes of age, or continued need for ventilation at 10 minutes, or within an hour of birth, having a poor gas, whether that be a cord gas or arterial, capillary, venous, with a pH less than 7 or a base deficit more than 16. So criteria A is pretty objective, straightforward. Criteria B is a little bit more subjective, and I'll go into a little bit more detail about that in my next slide. So you either need to have seizures or evidence of moderate to severe encephalopathy. So that's where you've got an altered state of consciousness and evidence of abnormal tone. There are a few special circumstances where you could consider therapeutic cooling, but we would always have discussions with our tertiary neonatal colleagues before even considering therapeutic cooling for the 33 to 36 weekers, and also those babies that have suddenly, unexpectedly collapsed on our postnatal wards, because the evidence just isn't as robust for these special circumstances. So, defining encephalopathy can be quite subjective, as I've mentioned, and our guidelines suggest using the modified SANAT scoring system, which is basically either having seizures or 3 of the following 6 categories. So that's problems with level of consciousness, either reduced or absent, decreased or no activity, problems with posturing, abnormal tone, weak or absent primitive reflexes, and then abnormalities in the autonomic system. So bradycardias, apneas, constricted pupils, these are kind of features that you would look for. And if this criteria was not achieved initially, it would be important that you keep reassessing. So after an hour, you would reassess again. And then after 2 hours, you could reassess. And then again at 4 to 6 hours. It's important to see if there's been any change so that you can initiate that cooling within that 6-hour period if it's appropriate. So as soon as you've recognized that you've ticked A and B, it's important to start the passive cooling process in our unit as soon as possible and record exactly when that's been done. And it's important also to do this in as a controlled manner as possible. So ideally, there should be a rectal thermometer that is used, and you're aiming for a target temperature between 33 and 34 degrees Celsius. From a kind of practical point of view, it may be as simple as switching off the heater on a resuscitaire. If they're in an incubator, switching the incubator off, opening up the portholes. But the temperature can dip very quickly, so it is really important to keep an eye on that temperature. And it may be that you need to remove, put blankets on, remove blankets to help keep that temperature within the target range. We don't use ice packs because of the risk of causing severe hypothermia. And we don't do active cooling in Harrogate, but we would wait for the retrieval team to come, and they have the specialist mattresses and can do it in a much more controlled manner and get active cooling started sooner rather than later before they're transferred to either a level 2 or a level 3 unit. We've also got to remember the risks of persistent pulmonary hypertension of the newborn in these babies. And when you're cooling them, you're increasing the risk of that as well. So making sure that you're not causing inadvertent hypoxia by doing cooling. So Erica's cases highlighted a few of the difficulties that we come across here on a level 1 unit. And one of them is maintaining skills, because we are such a small unit. And whilst we have a really highly skilled and dedicated staff, we do look after not only newborns, but children and young people up to the age of 17. And we recognise that maintaining neonatal procedural skills, whilst not dealing with them on a kind of frequent basis, can be tricky. And as a department, we minimise these risks by using helpful tools such as video laryngoscopies for helping with skills such as intubations. We run local neonatal skills days at least twice a year to help maintain skills of our staff members as well. Another difficulty that I don't think it's just our unit that finds hard is recognising seizures in newborns. There can be a massive amount of not only underdiagnosis of seizures, but overdiagnosis as well. I've got a couple of references at the bottom there. There's some papers by Mizrahi and Murray looking at, they looked at 526 epileptic seizures caught on EEG in neonates on neonatal units, and only 34% of those actually had clinical features at the time. So definite evidence of underdiagnosis of seizures there. And then there was another description of 177 events that were thought by just, day-to-day clinicians on a neonatal unit, thought to be epileptic seizures. And actually only 27% of them had EEG changes. So that's a massive 73% of events that were suspected as epileptic seizures and potentially treated as epileptic seizures, but didn't have any EEG findings at the time. So as a unit, we've recently obtained a cerebral function monitor. So hopefully going forward, this will help us as a team with the recognition of seizures in neonates. And then the other point I've put there is actually defining encephalopathy in the first place. I think as a unit where you're not necessarily performing neurological assessments on newborns on a daily basis, the SARNAT criteria can be a little bit tricky to interpret sometimes. And one of our doctors has suggested adapting the SARNAT criteria by adding in the Dubowitz neurological assessment, just to make it a little bit easier for our staff to do these neurological assessments. And I've just got a little screenshot of what that may look like, just to give people a better idea of how we can do these neurological assessments going forward. So that's a very quick run through of how we deal with HIE here on a level 1 unit in Harrogate. And I'm going to pass it on to Jade Kant, our team lead for physio, to talk about the longer term care of these babies with HIE.
Thanks, Mona and Erica, for that. So we're really lucky to have Jade with us, paediatric physio, because I think lots of us want to know about actually how we manage babies once we've discharged them home, in terms of trying to increase their long-term sort of function, really. So it's great to have Jade on the call in terms of physiotherapy. So thank you very much, Jade.
Thank you very much. So I'm Jade Kant. I'm currently the team lead at Harrogate, and I've been working in paediatrics for 20 years, and especially neonates and 0 to 5 for the past 13 years. So I'm just going to share my screen and go through what we do. There we go. I hope everyone can see that. So, initial physiotherapy assessment, what would we do? We do what, doctors and nurses do. We sort of observe how active the baby is against gravity and how they're moving their limbs. We also look as to whether they can turn their head, move it side to side, or also importantly, are they able to maintain midline for a couple of seconds? We'd look at their tone. We'd also look at range of movement. And we might use something like the AIMS, which is an Alberta Infant Motor Scale Assessment, which is a very simple tick sheet that gives you a score, and then it puts you on a percentile. So it gives you an idea such as like your height and weight. It gives you a percentile of where they're at. And we worry about all babies that present under 10th percentile. Sorry, this isn't that clear, actually, the picture's been blown up, but you can see it. We do it in the 4 different positions. So if they're on their tummy, back, when they're supported sitting and standing, and what position their limbs are in. So are they still flexed up? Are they able to lift their head, turn their head? Can they save their airway at the beginning? In supine, are they completely flat, or can they actually bring their hands towards their face, towards midline, and can they anti-gravity be able to kick their legs up, which we expect all our newborns to be able to do. We don't expect them to be able to hold their head up in sitting or take much weight through their legs when we hold them up. But this is done according to their age in months, and it begins at 0 and goes up to 18 months. So it's a very good assessment that you can repeat every time you see them and check which scale they're on in the percentiles and see if they're changing or dropping. So it's a good way to monitor them. The other things as a physiotherapist we don't just consider the active movement. We've got to look at the child as a whole, and if they may have an unsafe swallow. And earlier on, Dr. Helen, you talked that your case study had chest physiotherapy. So do they need this? Does it need to become part of routine if they're an outpatient because they don't have a safe swallow? Who should this be taught to? Because obviously once they go home, who's going to be the predominant carer and who's competent enough to be able to safely be able to do this? Because we often have to consider around feeds and not be doing chest physio after a feed, but also a certain amount of time before a feed, because often they might start coughing after the chest physiotherapy. So we need to be able to go through it and practice with families, with someone who's definitely going to be that main carer. Also, as a physiotherapist, we will be concerned about other parents bonding. Obviously, they've been through a traumatic event. Some of the, obviously the HIEs, level 3s are going to be more severe. And so we have a lower level observation score, an NBO, which will work on what the positives the baby can do. And they're what all the babies should be able to do. So no matter how low level they are, they should at least be able to have a reaction to the rattle noise or have a reaction to the light going across their eyes. And then you can help build that bond by saying, look, they can do this. Look what your baby can do. So you're helping to create that positive bond with the family and show them that their baby can do things. The other thing that, depending on the training of your physiotherapist in your teams, we can do teach baby massage. So I can teach that. And again, it's quite a typical thing over here in England that parents with babies that have been born straightforward and go home, they'll often do baby massage classes. So it's a positive thing that typical families would like to do. So it's also something hopefully lovely that families and carers can do and help create that positive bond and start to get that really good carer's ability and cues. You have to be able to read your baby when you're doing the baby massage. But the important thing is that it's also to help that bond is that no healthcare professional can do that baby massage to your baby. It has to be the carer, has to be mum and dad or the main carer. It's about them doing it, them having the experience, them talking to their baby, the smell, the reaction. So when we teach it, I use a doll. I at no point must I ever massage the baby. So I'm going to talk about quite a complex caseload that we have on our small area in Harrogate, but the inputs that can be required and that can be achieved in even a small hospital. So the patient ended up being a long stay inpatient. So we try and meet them as soon as possible. Any HIE grade 3s, assess them on the ward, and they presented typically as very low toned, especially centrally. But they also rested with their wrists in complete flexion, and they had a complete head preference looking one way only, and a very poor swallow, so unsafe to be fed. So the priority there was the poor swallow. So we devised a chest physiotherapy program that was to be carried out minimum twice a day. And we were coming to do that while they were an inpatient for the first few weeks. We then also looked at a stretchers and activity program. So because of the way that the child was resting with their wrists. We didn't want to lose range of movement so early on. And we also want to maintain head range of movement and neck, and reduce that head preference. But rather than it always being physiotherapy type stretches and activities, we can just say, why don't we do it during an activity song, such as singing songs, using toys and excitement of rattles and lights, or just parents or carers, because the babies under 3 months will typically prefer a face and voice, someone talking to them. So rather than turning the head the opposite way to their preference, we would go just be on their opposite side to which they like, for all nappy change, for all bathing changes, for all cuddles, hold them in the opposite way so they'll look up towards your face, talk to your baby, cuddle time, play time. So it can be incorporated into a typical day, not that, oh my goodness, I've got to fit physiotherapy in. It's how we went. We did also teach the parents baby massage, and the physiotherapist used a doll while mum carried out it on the child. The other thing that we instigated very early on is, because this child was such low level, is we're able to achieve and get a supportive play mat system for play mats, so that it frees parents' hands up and they can be in front of their baby and just play like a typical family, as opposed to thinking, how am I going to be able to hold them in this position and do this? So I've got a picture here of what it is. It's called a Squiggles play mat. But what I wanted to show you here is that obviously I can't advocate that you make it yourself, but actually it's a big piece of material with just long pommels with Velcro on, and you can build up. So all those long pommels, the green and the pink ones, can go on top of each other. So you can build a wall in front or behind them if you want to do side lying. And then it comes with extra those little thin green straps so that you can keep your child gently in side lying if you want to do some side lying play, which is a position physiotherapists will often really like at the beginning, is side lying play as opposed to being on their back. Because it naturally brings the hands into midline and into the visual field, and the babies do not have to worry about coming up against gravity, because the hands will just naturally fall into the midline. So often with these grade 3s, we will start off play positions, just say playing on your side, and if the babies do keep wanting to turn onto their backs or on their tummies, a play position like this mat can just free parents' hands up. It's really lightweight and portable. But the other thing it does for later on, because it comes as one kit in a bag, is the blue roll is much higher. You can see it's a much higher depth, and then you can do supported seating rather than get another piece of equipment in. And you can use that pink roll or the green rolls to go on top of the blue one. So if they don't have head control, you can give them full head and back control as well. And then you can put those rolls in front so they can't fall forwards, backwards or sideways. And again, it's freeing parents up to then sit in front and play with them and bring toys. This child will be on caseload for a very long time, and they currently are much older now, they're 15 months. And what we've done since then is they've gone home. We had to prioritize which part of the physiotherapy we should do for this family, because they felt it was overwhelming, which is absolutely fair enough. It's a lot. So we said, do you know, you really need to do the chest physiotherapy. This is about safety. And as they got confident with that, we then came back to the activity programs to promote midline play, being active and functional, finding out what tactile, what textured toys the child really enjoys. So is it the soft ribbons and scarves? Is it the hard, dry face cloths and sponges you've got in the house? Or is it like foil, like crinkly blankets? And I often say you don't have to go and buy expensive different textured toys. Go around the house, find that scarf, find that woolly hat, find that dry sponge that's not being used, things like that, that got all your different textures that aren't small and won't go in the mouth, but they can exploring it, enjoying, you'll find that there's always one or two they really enjoy, and then use that to encourage them to play, come into midline. But what we do here in England is we are very, very concerned about postural control and in making sure the children are always in midline. And so at 9 months, we got them into a specialist supportive seat, and I'll go through what that is on the next slide. And then at just over a year, we got a standing frame in. And what we're now looking at is a sleep system as well. So we're concerned about 24-hour postural management, so that we're trying to keep the trunk symmetrical. We're trying to keep the hips in joints and a nice hip, ball and socket joint right, and not subluxing, so it forms. The child remains low-toned, non-verbal, unsafe swallow, but is now able to reach for different tactile toys and continues with the chest physio and activity program, which is great. But in this slide, the first one I'm showing you is a side profile of the specialist seat they got. And I hope you can see that there's a head support and then a trunk support. But what is on the side is a lateral support. So it's holding the trunk on both sides. And you can get an extra one. So you're holding the upper trunk and then the lower trunk. But also what it's got is a pommel that will go in between their legs so that it keeps their legs in slight abduction and they can't slide forwards. It's got a foot plate, so you keep the feet ankle at 90 degrees. So when the child, we have to hope they can start standing, they'll always be able to have their feet flat on the floor. Otherwise, with their low toned background, they will have pointing feet and then they'll get tight at the back. So we're being preventative, and this goes in as early as 6 months if we know there's no chance of them starting to sit. But from 9 months, if there's no sitting, we would instigate this. And it does come with a tray, so then you can do play activities. And it also tilts in space. So if you're sitting your child up completely upright, if their head control is good enough, that's fine, they can play. But if you need to tilt their whole body but keep their angles all right, you can tilt it in space so they are more reclined, so maybe 30 degrees of being upright, and then play it. And the tray will be able to maneuver so that it still can be flat even when the chair's tilted, so that toys won't fall off. The next piece of equipment here is a standing frame. Very similar concept of it will keep your ankles and feet at 90 degrees, your knees in extension, a pelvic support which takes all the weight, and then a chest support and a head support, and again with the tray. And that we instigate from 1 year. And then the other thing that we now do in the next picture is a sleep system. The sleep systems are expensive, and so we ask families to sign a contract that they're willing to use these, because sometimes the children don't sleep on their backs by this age, but they have to accept they're willing to not give up straight away. And the different companies have breathable materials, and you can see that from the picture, it looks quite harsh without the blanket over the top, but once the blanket on, they're all really soft, breathable material that's also washable and wipeable. And most families usually want to go ahead with it because they want their child to be able to maintain range of movement and not get the dislocated hips, not get the flexed contractures at the knees. So are willing to try these sleep systems. They can also be adapted that if your child for swallow or safe reasons, the doctors decided that side lying is the safest, they can also completely support them symmetrical in side lying as well. So for this family, they're 15 months down the line. They still have ongoing chest physiotherapy daily. We teach family and grandparents as well as the parents. We are maintaining range of all the joints, but we're much more about function and play, about quality of life, but in the postural set. So we're not aiming for the child to be able to sit by themselves or be able to stand by themselves, but we're putting them in a piece of equipment that you can provide more support, so then they can free their hands up and they can get some quality of enjoyment of doing messy play, of being active and enjoying life. But at the same time, we are always thinking about postural support midline and trying to prevent scoliosis and the windswept hips and dislocating hips, and hip surgery. We know if we do start postural support early on, we can be preventative from all the surgery that unfortunately took us a few decades to work out that we can prevent. And that's what we do with our grade 3s, I would say, with all of them straight away. Thank you.
Great, thanks very much, Jade. I'm just interested in terms of the support systems that you say. How could people modify those for a low resource setting? Are they easy to use? Because they look quite high tech and expensive. So
they do, but I'm aware that in Nepal, they would use like a wooden frame seat that they already have for little children, and a tray that also is built over the seat. And then they literally use paper mache to pad it out and provide the extra support. Obviously, coming from England, I can't say that's what you should do, but I've got a physiotherapist from my team that has left and is currently working in Nepal. So I'm sure she would be happy for emails, or I would be able to email them and put in contact how they're managing to adapt equipment they can get, which is usually typically nursery sort of wooden chairs and seats, or slightly higher supports for attempt standing, and they've adapted it. And the physiotherapists within the team have helped and had help of volunteers to come and build quite a few, so they get a stock of them. So when that occurrence happens and they need it, they can come up with something to support the posture. It won't be as specific and high tech, and they won't tilt in space. But we know if we can protect the spine, we can then prevent the scoliosis, to then prevent the lung problems later on. And same with the hips, they won't get all the windswept and the hip surgery and the pain that they'll need later on if we don't try and maintain posture.
Yeah, thanks very much. And there's some comments in the chat about what using Uganda in terms of support. In terms of, so there's some physio centres that make homemade standing frames and chairs, and then obviously lots of rolled up blankets on the NICU. So just a question that's coming for you, Jade. So what is the earliest time to begin physiotherapy for a baby with neurological sequelae from severe HIE?
We don't have a guideline, but from my experience, I like to meet them on the ward, because the moment I can start a rapport with family and start to talk to them, I find we need to see them probably for their life. So if we can start off the journey positively and just introduce who we are and just ask them about, how do you think your baby's doing? How active are they when you've done a nappy change? Can they turn their head to your voice? Have you noticed if they are disturbed when you talk to them or sing to them? So that I'm giving them the power, empowering them to tell me about the baby, and I'm not going in and going, right, we need to do this physio, this stretch, but I'm starting off very gently, because they're going to need so much from us quite often. So that I would always say in the first few weeks, even if it's not a thorough assessment, it's the start.
Thank you. And then, so there's a question that's also come in, but I think you just answered it. How long does physiotherapy go on for, or is it a lifetime process? I think you've just answered that questions, but I think from what I've taken away, it's about being proactive, and actually we can prevent some of the long-term complications with active physiotherapy. And then a comment saying that in rural settings, you won't expect relatives to follow this up for a long time. So do you have programs for follow-ups at home? And then I think just really a question to all the Ugandans on the call about how do you maintain that they continue visiting the centre? But I guess from what you said, Jade, it's about getting the family involved before they go home from hospital, isn't it?
Yeah, if you can. Otherwise, I will go out to the house if that's an option, if they can't come in, because sometimes it's coming back to where the event happened or all the trauma that comes back. So I'm lucky enough, I work in a community setting that I can go out and do a home visit. Where I previously worked, I wasn't allowed to, so we did always have to invite them in. And that's why it was so important to get in the first, usually month by month 2, to start off and show them that it can be a positive experience coming back to the hospital where it went, and that they just tell me what their baby can do. And that's where I often think the starting off with the baby massage can actually be a really nice introduction to the physiotherapy that they're going to probably need for life.
Kath. So for those who aren't aware, there's a baby Ubuntu program. It runs in various countries. There's trainers in Kampala, but you have to excuse me because I'm not sure if it's Kyokutambe or Mulago, but also in Kyokutambe and in Bali, they've trained up master trainers. It's a really lovely program, and it basically does all the amazing stuff that Jade has described, but in a resource limited setting, with what's available, and there's so much to learn from it. So it really, to answer Stella's question as well, we have one locally trained midwife as a physiotherapist stroke neurodevelopmental specialist stroke a bit of everything. She forms a relationship in the neonatal unit with the mothers, primarily of those with HIE. It's really important. It's such a devastating disease, as we all know. She's able to form a bond with them, talk through it. She does do the massage, Jade, but she teaches them how to do the baby massage. And we just use locally purchased sunflower seed oil to do that. She shows them some basic physiotherapy, and they continue to do that. And then we follow them up in a high-risk clinic, and then we use something called the Malawi Developmental Assessment Tool, but as a basic one called the IDEC, which again, if we could get interest and some funding from somewhere, I'm sure we could get the team, the Ubuntu team, to train more programs across Uganda so that more of us can run such a program. And then it finally feeds into an early intervention program, which is an 11-module course that supports families and the children who have developed impairment or cerebral palsy. So do have a look at that website. We're lucky enough to have been able to implement it here in Bali, and also I know Kyokutambe and one of the hospitals in Kampala, but there's a lot of you on this call, and it's a really valuable resource, and we won't quite achieve what Jade has described, but we shouldn't be put off that we can't do it, because there's a lot that can be done for these babies. And I think just lastly to say, the involvement of the mothers on the ward with these babies, doing the massage and doing the exercises, is maybe not the way it's done in the UK. We obviously only have limited resources here, but I personally see that involvement of the parents as being hugely beneficial, and they feel like they're contributing to the improvement of their babies. So I wish we all had a Jade. We don't. Jade, you're very welcome to Uganda, to all of our neonatal units. But please, everybody, what Jade has described to us today is probably quite new and novel to many of you on the call, but let's embrace it and let's do the best we can with developmental care and early physiotherapy. Not to dismiss all of the wonderful nursing and doctor colleagues, but it's just unusual and really fantastic to have allied health professional on the call. So thank you for bringing that element into the talk, Jade.
I completely agree, Kathy. It's amazing. And I think even for us in the UK, it's so interesting to hear what Jade does, because we obviously just, if we have a baby with severe HIE, we pick up our phone and ask Jade, those sort of things. So it's really interesting to hear what you do. I've heard some really interesting presentations about how to manage our babies with HIE. And I think, yet again, it becomes apparent that we're all facing the same challenges, whether we're in the UK or in Uganda. So finally, I'd just like to say a really big thank you to all of our speakers. So great presentations from Helen, from Clare, Mona, Erica, and from Jade. We've sent round the PowerPoints to everybody who's registered, so you can have a look at the slides in your own time. And then, as I said, if you have a look at the chat, there's some fantastic links and resources in there. We will be sending around a feedback form, so please feel free to fill that in, because that helps us develop the topics for the next sessions going forwards. And then just a date for your diary, the next talk grand round is on the 17th of November, the same time, 12 o'clock UK, 2 p.m. Ugandan time, and we're going to be talking about kangaroo mother care. And we've got presenters from our LMS from Pinderfields, doing that from the UK, and then we look forward to welcoming our Ugandan colleagues onto that call. So thank you very much, everyone, for joining. Thank you for all the questions and the comments in the chat, and I wish everybody a very happy weekend. Thanks very much.